Good morning. The subcommittee will come to order. Thank you all for joining us for today's subcommittee hearing, Choice Consolidation, Evaluating Eligibility Requirements for Care in the Community. Today's hearing is our first of the new year, our first during the second session of the 114th Congress, and most importantly, our first in a series of hearings that we'll be holding on different aspects of the Department of Veteran Affairs plan to consolidate care in the community under the Choice program. The VA currently uses 7 mechanisms to provide care to veterans patients in the community. Each of these 7 mechanisms works differently, using 7 different eligibility criteria, 7 different reimbursement rates, 7 different administrative processes, and 7 different sets of business rules. Recognizing that using multiple means to achieve the same end was confusing and inefficient, Congress required the VA to develop a plan to consolidate all 7 community care programs under a single umbrella, a new improved Choice program. The VA provided the bare bones of that plan last year, and over the next several weeks we'll examine it in depth, beginning with today's conversation on eligibility. Determining who will be eligible for what and when under the new Choice program is perhaps the most important of all the discussions we'll be holding over the next few months. Eligibility for care in the community now is determined largely by how long veteran patients have to wait for an appointment, how far they have to drive to get to the nearest VA medical facility, and when they get there, whether the VA can provide the service that they need. While these existing criterions are not perfect, VA's proposed plan does not change them significantly. The VA's plan does include several significant changes to eligibility criteria for emergent care. However, by authorizing veterans to seek care in urgent care centers and requiring cost sharing for emergency care services in non-VA centers in order to incentivize appropriate behavior. I'm cautiously supportive of the eligibility criteria that the VA has laid out in the consolidation plan, though I remain concerned about many of the lack of details that the plan includes. Moving from 7 disparate methods for referring veterans to community providers to one streamlined, common-sense program is certainly necessary, but changing the status quo is never easy, and as the saying goes, the devil's in the details, precious few of which the VA has provided so far. That's why I'm glad to be joined this morning by Dr. Baligh, Yehia, the new Assistant Deputy Undersecretary for Health for Community Care, who's leading the VA's consolidation efforts. I'm hopeful that Dr. Yehia will be able to provide us some of the concrete details about how the VA will determine eligibility under the new Choice program that the plan did not include, and I'm looking forward to that discussion. I'm also glad to be joined this morning by representatives from many of our veteran service organizations. As veteran advocates and veterans themselves, I look forward to hearing their unvarnished opinion about the proposed consolidation plan and whether they believe will help us accomplish our most important goal, which is increase access to high-quality care for veterans we are all here to serve. I thank you all for being here this morning, and now yield to the ranking member, Ms. Brownlee, for any opening statement she may have.
Thank you, Mr. Chairman, and thank you for calling this hearing today. After more than a decade of war, veterans deserve to have ready access to the best health care available to them. Time and again, that is shown to be care provided by the VA. I'm pleased the VA is here today to talk about their new Veterans Choice Plan that will consolidate the 7 disparate care authorities that exist currently in law. This plan, submitted to Congress in 2015, would bring under one umbrella a program that is easy to understand and, more importantly, to implement. The program is intended to bring high-quality, safe health care to veterans wherever they choose to live. When Congress passed and the President signed the Veterans Access, Care, and Accountability Act in 2014, this was a promise to all veterans from all eras that they would get the care they earned on the battlefield in defense of our nation. The Choice program was rolled out in a rushed timetable under conditions dictated by Congress. I believe the department implemented the program to the best of their ability under trying circumstances. Today, Mr. Chairman, I'm interested in hearing from the VA what the estimate of this new care in the community will cost and how long it will take to implement. Also, what this consolidation ultimately means for veterans and their access to quality health care. After all, making it easier for veterans to access care is the goal that we all have in this room of this plan. One aspect of healthcare often overlooked is helping those navigate the system with physical disabilities that force them to bring a caregiver with them. I've introduced legislation that would authorize payment of beneficiary travel expenses in connection with the care of a veteran with vision impairment, a spinal cord injury or disorder, or double or multiple amputations whose travel is in connection with care provided through the VA. It is important that all veterans have access to quality health care, whether at the VA or in the community. But the care needs to be at the standards we have come to expect from the VA. I look forward to hearing from all of the witnesses today. I thank you for being here and moving forward in the coming days to bring the very best quality care to all of our veterans. And I yield back, Mr. Chairman.
Thank you. Joining us on our first panel this morning is Adrian Atizado, the Deputy National Legislative Director for the Disabled American Veterans, Carl Blake, the Associate Executive Director of Paralyzed Veterans of America, and Duane Williams, Georgia Leadership Fellow for the Iraq and Afghanistan Veterans of America. Thank you all for being here today, gentlemen. Mr. Atizado, we'll begin with you. Please proceed with your testimony.
Mr. Chairman, members of the subcommittee, on behalf of the 1.3 million wartime ill and injured veterans of the DAV, I want to thank you for allowing us to testify today. You had asked to examine VA's plan to consolidate certain authorities that it uses to purchase care in the community into the proposed new Veterans Choice Program. You also asked us to assess whether the proposed eligibility criteria to access the new VCP are sufficient to increase access to care among veteran patients. The way we see it, Mr. Chairman, we believe VA's entire plan will increase access to care, no doubt. Whether it is sufficient, though, will remain to be seen. So, for example, the plan proposes to continue the existing geographic and temporal eligibility criteria of the current Veteran Choice Program, as well as the availability of services criteria currently utilized in other authorities such as dialysis and PC3 contracts, as well as the now defunct fee-basis care. All these criteria have their own limitations and vulnerabilities from veteran patients' perspective in allowing them to access care in the community. Now, on a system level, these criteria would continue to administratively separate the new VCP from the VA healthcare system, which we believe does not foster full integration and limits the performance of these networks to the detriment of veterans' patients. Under the separated construct, Mr. Chairman, we recommend serious consideration that the eligibility to use the new VCP should mirror their current eligibility for VA healthcare, giving the highest priority to service-connected veterans. However, DAV also believes clinical decisions about when and where and with who to receive care is one that should be between a veteran and his or her doctor without bureaucrats or regulations getting in that way. Under this construct, all of VA's authorities are consolidated, and its medical benefits package reflects what is generally available and acceptable in the private sector. The seamless integration of community care into the VA healthcare system would be able to provide a full continuum of care. From a veteran patient's perspective, the future VA healthcare system with the integrated VCP should be responsive to the decisions between veterans and their providers. Veterans should be able to choose among the options within VA and the new Veteran Choice Program network and schedule appointments that are most convenient for them. For emergency and urgent care coverage, we applaud VA for including them in its plan. In fact, the AV had specifically urged the inclusion of urgent care in the VA's medical benefits package and to better integrate emergency care with the overall healthcare delivery system. However, there's nothing more glaring that will deter appropriate access to emergency and urgent care in the community as it plans imposition of co-payment to all veterans with little relief. VA clearly knows the value of ERs and urgent care clinics and their appropriateness as clinical settings because it owns and operates them in VA facilities across the country. If certain veterans do not pay co-payments today when receiving VA emergency and urgent care, we question why VA's imposition of co-payments to all veterans who receive similar care in the community. Simply put, if the future VA healthcare system with integrated new Veterans Choice Program are unresponsive to the medical needs of veteran patients, why should veterans be penalized with a co-payment for a healthcare delivery system's shortcomings? At the very least, service-connected veterans should not face greater restriction in the future VA healthcare system when accessing care in the community. Finally, Mr. Chairman, we understand the scope of the consolidated plan is limited. However, we do caution Congress and the administration on this fragmented approach to providing veterans timely access to care in the community. If Congress intends to increase veterans' access to high-quality care across a continuum of care, including care in the community, not addressing gaps and inconsistencies in VA's plan, in VA's medical benefits package, as it sits against all available services in the community. We believe that VA will assuredly continue certain fragmentations of care that veterans experience today into the future. Veterans could be left unassisted across different providers and care settings, fostering frustrating and unsafe patient experiences, leading to medical errors, waste, and duplication that foster poor overall quality of care. You have our commitment, Mr. Chairman. The DAV stands ready to work both with you, the Congress, and VA to ensure veterans have ready access to high-quality care, both in VA and in the community. Mr. Chairman, thank you for your time and attention, and for the opportunity to present this testimony. I would be pleased to answer any questions you or members on the subcommittee may have. Thank you.
Thank you, Mr. Atizado. Mr. Blake, you can go ahead.
Thank you, Mr. Chairman. Chairman Benishek, Ranking Member Brownlee, members of the subcommittee, on behalf of Paralyzed Veterans of America, I'd like to thank you for the opportunity to testify today. Let me say up front that we believe that the VA's Community Care Consolidation Plan lays out a positive path towards the delivery of timely quality care and improving access for veterans. However, we do believe that there are questions that remain as it relates to the veterans that we serve, veterans with catastrophic disabilities like spinal cord injury and disease. As eligibility dictates access to health care, so too does the capacity of the systems to provide that care. Over the years, the VA healthcare system has relied upon a number of methods and standards to measure access and timeliness of healthcare delivery. We have seen the VA standard evolve from the 14-day wait time to the 30-day wait time. We've seen Congress and the administration seemingly accept an arbitrary 40-mile geographic-based access standard. The fact is, there is no evidence to suggest that arbitrary wait time standards are an indicator of quality. Rather, they are bureaucratic tools to self-assess output performance. They are not a measure of quality care. To suggest otherwise is unfounded. Similarly, geographic-based access standards are not derived from industry best practices for the provision of health care. The independent assessment on access standards conducted by the Institute of Medicine determined that industry benchmarks for healthcare access vary widely throughout the private sector. IOM was unable to find national standards for access and wait times similar to the Veterans Choice Program 40-mile and 30-day standards. PVA, along with our partners in the independent budget, DAV and VFW, strongly agree with the IOM's recommendation that decisions involving designing and leading access assessment and reform should be informed by the participation of patients and their families and their providers. We believe that this concept will also best serve the needs of our members and all veterans. The irony of all this discussion about access standards is PVA members often travel farther than any other population in the specialized population of veterans, or even all veterans in general seeking care from the VA. It is not unusual for PVA members to travel more than several hundred miles to reach one of the 25 SCI centers of care in the VA system. They do this because the VA SCI system of care is far and away the best option that they have to meet their specialized healthcare needs. The access problems these veterans face are usually not wait times or distance. They are the burden of cost. Ms. Brownlee, I'd like to thank you for bringing attention to that issue in your opening remarks. As a result, veterans may wait to be seen until their condition deteriorates requiring more costly and intensive care. This subcommittee is reviewing the question of eligibility without even considering this important fact. Congress should expand travel benefits to include non-service connected, catastrophically disabled veterans who are already granted a higher priority in the system to ensure that they are able to receive quality specialty care. PVA believes that the 30-day and 40-mile eligibility standards that determine access under the new VCP do not consider what is best for veterans with catastrophic disabilities, to include SCI and D, or any other veteran seeking care for that matter. PVA, along with our IB partners, also support the plan to expand emergency care and urgent care in the community. However, we strongly oppose the proposal to charge $100 as a co-payment for emergency care and $50 for urgent care. This proposal seemingly makes no exception for veterans with service-connected disabilities who are currently exempted from co-payments. These veterans should not be required to bear a cost share, as it may disincentivize that veteran or their caregiver from accessing emergency treatment or urgent care, defeating the whole purpose of expanding these two opportunities. As an alternative, VA should also consider establishing a national nurse advice line to help reduce over-reliance on emergency room care. The Defense Health Agency has reported that the TRICARE Nurse Advice Line has helped triage the care for TRICARE beneficiaries. Those who are uncertain if they are experiencing a medical emergency and would otherwise visit an emergency room call the Nurse Advice Line and are given clinical recommendations for the type of care they should receive, when and where they should receive it. This advice line must also include SCI-trained providers who are able to identify potential complications specific to an SCI or D veteran. Mr. Chairman, I'd like to thank you again for the opportunity to testify. Be happy to answer any questions that you may have.
Thank you, Mr. Blake. Mr. Williams, go ahead.
Mr. Chairman, Ranking Member Brownlee, distinguished members of the subcommittee, on behalf of Iraq and Afghanistan Veterans of America and our 425,000 members and supporters, thank you for an opportunity to share our views with you at today's hearing. By way of introduction, I'm a retired Army person, having served 26 years active duty, 6 years in the reserve. I serve as the chairman of the Veterans Affairs Advisory Board of DeKalb County, Georgia, and I'm responsible for a veterans recognition, advocacy, and research program on behalf of 41,000 veterans in that county. I also serve as the Iraq and Afghanistan Veterans Leadership Fellow, focused on veteran leadership, development, policy advocacy, and team building. These experiences help me to understand the needs and challenges of veterans' access and quality care. IAVA is proud to have previously testified in front of this subcommittee recommending the need for consolidation of care in the community of veterans enrolled in VA health care. We applaud Congress for requiring VA to put forth a plan for consolidation. We recognize the senior VA leaders for acknowledging the need for consolidation and for providing inclusive, veteran-centric, and transparent plans. The 2015 Choice Improvement Act helped begin the process of removing confusion for veterans. However, IAVA's most recent member survey indicated that 5% of the respondents had used the Choice program, and their reviews were mixed. For the 95% of IAVA members who have not used Choice, 43% didn't use it because of confusion on how to use it, and half were totally unfamiliar with the program. In Atlanta, Georgia, the enrollment for health care at the Atlanta VA Medical Center is growing faster than the capacity for primary care. According to the 2013 VetPop data, the number of veterans living in the 28-county metro Atlanta area was 294,000. By 2014, the data reflects 361,000 veterans living in the same area. And during the same period of time, the Atlanta VA hired 600 additional employees. Related to this, on January 20th, the Atlanta VA stated that the current completion for VA primary care appointments was 60 days. But by January 26th, the director advised me that the wait was reduced to 20.6 days. If these numbers hold true, The reduction in wait time by nearly 40 days within 6 days is remarkable. We hope other VA medical centers follow suit. We hope this subcommittee will continue to monitor, analyze, and ensure the accuracy of wait time data. As Congress moves forward to simplify this process for veterans, IAVA recommends that the Congress works with the VA. Use the VA as a plan as a framework for legislation to avoid the one-off proposals that might be misinformed or put politics ahead of veterans. After all, the Congress provided different plans that added to the confusion and inefficiencies, leading to the need to consolidate care. We believe Congress should be mindful of these lessons, learn from them, and leverage the VA's plan as a framework for consolidation of care. Our second concern is VA's ability to effectively implement a plan to consolidate care across VA to avoid the mistakes made during the implementation of choice. While the Choice Improvement Act of 2015 extended provider eligibility to any provider meeting VA criteria, the VA must use this opportunity to streamline and standardize the medical documentation requirements. Under the 2014 law, reimbursement rates for non-VA providers is limited to no more than Medicare. Reducing the administrative requirements can remove a barrier to more providers joining the network. VA intends for its health delivery model to be a patient-centered medical home for veterans. Therefore, VA holds responsibility for the direct coordination of services for each veteran. Care coordination is a core function of primary care. Significant numbers of VA patient needs are complex. The factors that increase the complexity for our veterans are a number of them have multiple chronic health problems, social vulnerability, a large number of providers, and the patients lack the ability to coordinate their own care. Significant numbers of VA patients have anxiety disorders, dementia, depression, and kidney failure. IAVA recommends VA continue to collaborate with all stakeholders who share their vision to put the veterans first and focus on value-based leadership to change the VA culture. Given the shortcomings related to training frontline personnel and the implementation of choice and customer service, VA should continue to put forth efforts to train all employees in the consolidated care model. Finally, IAVA encourages the Congress, VA, and VSOs, the industry, and other stakeholders to place increased importance on the quality of care that veterans receive, especially providers who haven't served veterans since their residency training. In closing, thanks to this subcommittee for your leadership and your commitment to veterans. Mr. Chairman, I stand ready to answer any questions you may have.
Thank you, and thank you all for your statements. I'm going to yield myself 5 minutes for my questions. You know, as a doctor who took care of veterans in my private practice and, you know, with some VA coordination and also working at the VA doing care, many of the things that you brought up today, you know, I've experienced, you know, in reality. And the frustration of veterans that I hear from now and, you know, the work that my staff does to try to get veterans into care is so frustrating. And having a single system that really is based on clinical need makes much more sense. And I completely understand that. And the whole difficulty with the criterion, I think, is the effort to contain costs. And one of my biggest gripes in my time here has been the inability to figure out what it actually costs the VA to take care of a patient. So, you know, we don't know if care in the community is more expensive than care in the VA, frankly, although, you know, it seems to add more to the total cost. But let me just ask a couple questions that have come up based on your testimony and some of the written statements. The Military Officers Association of America, for example, called on the elimination of this access standards and the establishment of a clinically based access standards instead. Can you elaborate a little bit more on your thoughts in relating to that? I mean, you know, the miles and the time versus what's clinically right? Does anybody want to comment on that? Mr. Atizado, can you talk to me a little bit more about some of the things you brought up in your statement?
Sure, Mr. Chairman. I think first and foremost, what has to be said is where we come from, which is from the patient's perspective. This plan really comes from a systems perspective, from a provider's perspective. And what we're trying to say is, in order to simplify eligibility and to ease access to care, whether it's in VA or in the community, there should really just be one eligibility criteria. Once you're enrolled in VA, you should have the option to use VA or the community, whichever is most convenient for the patient, as it relates to the doctor's recommendation. Unfortunately, as you had mentioned, these criterias are really cost containment measures, and we understand that. It's a feature of the healthcare system today, and most likely will remain a feature in the future VA healthcare system. But by and large, the approach in the plan really is to disincentivize or make harder accessing care in the community. We think it should be the other way around. The plan should incentivize veterans to use VA, not disincentivize them from using the community. The plan should simplify accessing care as patients see it. It's very simple.
I agree with you.
And our proposal really does that. Once you're in, you're in.
Mr. Blake?
I think it's fair to say that part of the reason the Institute of Medicine couldn't find examples of 30 days and 40 miles is because that's not how the larger healthcare system in America works. I think it's based on the idea that I meet with my provider and we determine as a partnership, as it were, what's best for me as a patient. When should I be seen? Where would it be most appropriate for me to be seen? What procedure would be most appropriate? And while I think on some level that exists in VA in some places, the strictures that are in place right now, as Mr. Atizado mentioned, allow it to be maybe more rigidly managed. It's just not optimal. That's why we've joined with our partners in the IB to say that the VA should move to a clinically based access standard. I don't know if Dr. Yehia would admit it, but we were involved in a lot of the meetings, and I think they understand that. But they have to figure out how to develop a workable plan within the construct that they have available to them. I think 30 days and 40 miles allows you as the Congress to control based on how much it's going to cost. And if you open up the possibilities with a clinically based access standard, it's a little more uncertain what the cost might actually be.
Well, my thoughts in talking to some of the VA administrators that I've talked to has said that, the different rules make their bureaucracy work so hard to try to get people into one or the other one of these criteria that we have now. It's just slowing the whole process down, and I think streamlining the eligibility would help in that regard, because that's the biggest complaint I've had from the VA. Mr. Williams, do you have any further comments on that?
Mr. Chairman, the only thing I would do, if I put that in the context of the patient-centered medical home, the primary care physician has to be the person that decides what type of care the patient needs and what frequency they need. And I would think the VA's primary care provider would know that. That's a frustration I dealt with myself. That provider ought to be able to say that this patient needs to be seen for a specialty care at this point, and I need that information back to me within a reasonable amount of time and get that done. And they have to do that for the patient.
Thank you very much. I'm out of time.
Thank you, Mr. Chairman. I think your statement regarding we really don't know what the cost of VA care is versus community care, we really don't know the answer to that. And that's a fundamental, I think, piece of data that we really need to understand. And I was just wondering for all three of the panelists here, based on your organizations and the research that you do to support our veterans, if you have any sense of an answer to that sort of fundamental question in terms of health care delivery through the VA versus community care.
I would only offer this much. I think there's been a number of studies that have probed at the question about cost differences, and no definitive answer has ever been delivered. I think from the perspective of having done some of the budget work with the independent budget, I think the challenge is the VA healthcare system is not the private healthcare system, and we have to accept that up front first. So you can't just assume you can't make it an apples to apples comparison even down to cost, because the nature of the system and how it provides its services is not entirely reflective of the private healthcare system. So I don't know that we can ever get to a definitive answer, and maybe that's the challenge. Maybe we need to set that aside as the question. Unfortunately, that's a key focus that Congress has to be focused on, because you decide how much resources the VA is going to have to operate, and I don't envy that position that you sit in.
Yeah, I just think, intuitively, there are some services that veterans receive. I'm thinking about, getting your eyes checked and getting a pair of glasses, or audiology services like that. What seems to me would be cheaper if that was all handled, within the community, than for veterans having to travel long distances and so forth and so on to get to their VA. So, I think it's a hard question to try to answer, because I think it probably breaks down into a lot of different pieces as it relates to kind of specialty care beyond primary care. So it gets difficult. Mr. Williams, you had mentioned some of the surveying results that you've done with your organization, and you said that, I think you said that 43% of your veterans aren't utilizing the choice program because of confusion. Did you get any results in terms of veterans not using the program because the providers weren't there in the community and set up with the VA to be able to provide that care at all, or?
I don't think that was part of our surveys. I'd have to get back with the IAVA leadership on the availability of providers in the community.
Because I think that, we hear a lot about the choice program, and, I think in some sense about what we're talking about today and consolidating all of these programs. I think we all agree that consolidating these programs for community care is a good idea. This criteria for access is up for debate, but I think the consolidation piece, minimizing the confusion for the veteran, I think we all agree that's absolutely the right way to go. And I think part of some of the criticisms that I hear, I was just talking to one of my colleagues from Florida earlier this morning, and she was bending my ear about how the choice program in her district is just not working, and she's hearing a lot of complaints from her veterans about the program and access to the program. So I don't know where I'm really going with this, but I do hear a lot of feedback from people that are still, I know that there's a lot of work to increase the amount of providers in the choice program specifically, but I don't think that we're, again, probably in some areas we have the right amount of providers. In other areas, certainly in my district, finding the providers has still been a challenge. So even if you wanted to utilize the program, even if you were willing to do all of the research to figure it all out, and you met the criteria, in some cases the providers simply just aren't there yet. And perhaps part of that is because of the confusion. But I was just, I'd be interested to hear from your two other gentlemen about just, and I have like 2 seconds left now, but maybe we can talk about it later, what the feedback is from your members in terms of the success or challenges within the program. So I will yield back.
Mr. Heelskamp, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I'd like to follow up on the questions from Ms. Brownlee about the provider network and see how we can. I think Mr. Williams talked about reducing some of the administrative burdens. I will say in the 1st District of Kansas, which I represent, it's probably the most rural and least served district by the VA. There are no VA hospitals, but I have 70 community hospitals. And I just got the numbers last week. We have 1,309 providers, and that doesn't mean they're all happy. And to get into that network, they're willing, but the administrative burden is overwhelming. Every one of these facilities has been certified by Medicare for years. Now we have a separate certification process through the VA. From Mr. Williams, that you brought up in your testimony, are there things that you can recommend that we can get the VA? Could you reduce the administrative burden so these providers are there? They're ready and willing. They'll take the Medicare reimbursement, which beats Medicaid. The Medicare, they'll take that reimbursement, but the paperwork is much, much more intensive than anything else in their network. So some input from Mr. Williams, Mr. Baligh, or Mr. Atizado on that.
Sir, I will just have to say, and this is pulling away from that, but I met with some of the leaders from the Georgia Medical Association, and that was one of their concerns when it comes to the cost of physicians working in the network was the administrative cost that it cost their physicians, because they were even concerned about reimbursement rates for Medicare and Medicaid versus administrative requirements. But they brought up that that was an issue with their participation in choice, was the simple administrative overhead.
Yeah, Mr. Blake or Mr. Atizado?
Mr. Kielskamp, thank you for that question. I guess I think the first thing we need to recognize is that the choice program really is a pilot program. It's a temporary measure that was meant to address an access issue. The administrative rules as it relates to the law that was passed adds to that confusion. I do understand from Ranking Member Brownlee's question that whether or not the networks are in fact meeting the need is a two-way street. You know, TriWest and HealthNet have, in my estimation, tried to do a tremendous job in creating a national network in so many months, and not having the appropriate description of demand from the VA healthcare system makes that job a little bit harder. I do believe that network is working much better now. They are increasing appointments at an incremental rate. But the administrative burden for providers to join any kind of network is inherent, right? If we want providers to be of a certain quality, they have to meet certain standards, whether that be Medicare, so be it. Part of the Provider Agreement Authority legislation that this subcommittee has been wrestling with is that. Who are the providers we would want our veterans to seek care from? We can make that as hard or as simple as possible, but that really is a feature that is within our control.
I think you raise a great point, and especially your first point about this being seen as almost a temporary program as to deal with a problem. I will say in rural areas, this is an ongoing problem, and it didn't just start last 2 years ago. You drive hundreds and hundreds and hundreds of miles, and you're driving by 10 hospitals to get to the VA hospital, then you wait in line. And that's not good enough. And I think we've heard from the VA as well. They see this as temporary, a pilot program, and approach that maybe 2 years from now it might go away. I will note the committee, don't forget the House bill didn't have some of these arbitrary standards, and we had some cost concerns, and I understand that. But what's magic about 30 miles? What's magic about 30 days or 40 miles? There's not, other than you have to drive that. And so I appreciate the input on that, particularly. And so I don't know, are veterans still just presuming, and maybe Mr. Williams particularly with your survey, are they presuming this is just a pilot program and it'll go away and there'll be another variation of this in the future? And does that limit their participation? Or any of the three? Yeah.
Go ahead. Well, I wouldn't say they presume it. I mean, it is everybody, I think, understands that this program will sunset either on a date certain or when the money runs out. You know, your district is one of those ones that's always sort of befuddled me. It was sort of tailor-made for the old fee basis standards, which had written in regulation geographic inaccessibility. And for the life of me, I never understood what it would take to define it. That's what was attempted with the choice program with 40 miles in particular. Adrian mentioned an interesting point about the networks that TriWest and HealthNet are trying to build. The challenge is building a demand-appropriate network. Within the construct of the framework that we've proposed with DAV and VFW is the idea that through the integrated network, which is the right way to deliver care by and large, it needs to be distilled down to the most local level. Mr. O'Rourke looked at this idea in El Paso. They went out and figured out exactly what the community was capable of, particularly in the area of mental health, to figure out what it would take in a partnership between VA and the community to meet demand. All that being said, most of our members, from the PVA perspective, just don't use choice because the networks do not meet the demand that they have. And at the end of the day, the private sector struggles to meet the unique needs of SCI veterans, blinded veterans, veterans with polytrauma. So there's a complicated circumstance that exists here where the VA has to meet demand for principally primary care and mental health care, which are the big elephants. But it can't forget that there are many veterans who the VA is their only and best option, and how that gets right-sized with whatever the new VCP ends up looking like.
All right. Thank you, Mr. Chairman.
Dr. Ruiz, you're recognized.
Thank you, Chairman Benishek, Ranking Member Brownlee, for holding this series of hearings centered on VA's proposal to consolidate community care. We've asked the panelists to tell us how they would modify the eligibility standards that are necessary to create a veteran-centered VA. But to answer these questions, we need to look at the cracks that the Choice Act has left behind, or the cracks within the Choice Act, because these are the cracks that our veterans are falling through. And these are the experiences of veterans in my district that do not reflect the successes that the department boasts. So my first question are, can you specifically identify what are those cracks? Which of our veterans are not getting the care through the choice program that it was intended to do?
I'll give you a good example. Congressman Ruiz, veterans who need home and community-based services. The choice program does not allow VA facilities or doctors, no matter how clinically appropriate it is, to use choice money to buy home and community-based services. In fact, only home and community-based services, as we all know, is a cheaper alternative to institutional care, less expensive, more veteran-centric, is skilled nursing care. That's it. Out of all the home and community-based services that veterans can receive, that VA can provide under existing law, that is it.
How about you, Mr. Blake?
Well, I would say that the choice program is simply not built to meet the specialized healthcare needs of veterans like SCI and D, substance abuse, polytrauma, and TBI, blinded veterans. I think there's that wide spectrum of unique populations of veterans that VA serves. I don't think the choice program is designed to serve because while they might be able to go outside the system, only in a perfect world might it work, where full integration with the community so that it's seamless, but that might be a dream.
No, I think one of the problems with the eligibility criteria of a 40-mile distance is that you can have a VA clinic that does not offer the specialty care that our veterans need. For example, in my community, we have a clinic in Palm Desert in the center of the Coachella Valley, but it does not have a pain specialist working at that clinic. Does not have, for example, a dentist or other specialty kind of care. So our veterans still have to travel an hour and a half to the VA hospital to get that kind of specialty care. So when you talk about clinically appropriate eligibility, is that what you mean? Like making sure that it's what they need in terms of the specialty care they can acquire if it's not within the 40-mile distance?
Can I answer this one?
Yeah, go ahead.
Congressman Ruiz, what we mean by clinically based decisions is when veterans get to access the community care network. The way the plan is, and even when the choice plan as it stands, it really requires veterans to, one, enroll in the VA healthcare system, and then two, be eligible for the choice program or even this new choice program. So it's really two separate eligibility criteria to begin with.
Yeah. I think that we need to take pause and throw out a big caution out there. Many of our veterans are working poor, retired, or work in rural areas. And we are working under the assumption that in those communities, for some reason, those services exist. I come from an area that has both affluent and underserved communities, and I can tell you that in the underserved communities, you don't have specialists, you don't have community homes, you don't have any of the care that we are assuming that veterans can achieve outside of the VA. So I think that we have to really identify and not think that because we have the choice program, because veterans can go to their neighborhood doctor, that they're going to get the care that they need. We need to take into account the insufficiencies and the lack of resources in a vast majority of America that live in rural communities as well. The hotline. Tell me about the hotline and what evidence is out there that it actually saves money and also incentivizes patients to use the
Well, I think,
VA.
as a reference to my testimony, what they've done through TRICARE shows that it is certainly a workable solution. That's not to say that TRICARE is the model of perfection in this case, but I think what we're trying to do is ensure that veterans are making the right decisions when it comes to emergency care and urgent care. I think we all believe that urgent care is a must. It's something the VA has not really ever done, and unfortunately, I think you've seen in the community, in private sector now, a lot of healthcare is delivered through an urgent care setting. And so it's probably time for the VA to get involved in that, because that alleviates the pressure on primary care in the healthcare setting in VA. It relieves the pressure potentially on the mental health care, which is a big part of it.
Urgent care was a result of a failed primary care system where people weren't able to access their primary care, so they needed a quick in and out type of thing. But it can't replace primary care, because when we're talking about a medical home, a place where a patient can get integrated care with case management that can really take care of the entirety of the patient, urgent care doesn't necessarily provide that as we think of them now. So there are some benefits to urgent care, but we also have to make sure that the veterans also get home-based, comprehensive primary care that they deserve.
I agree with you, Congressman Ruiz. Yes, primary care is integral in coordination with care, but primary care is not all. And it never will be all. And you're right, urgent care has a place. There is an appropriate setting for seeking care in that, and we don't think veterans should be penalized because that is the appropriate setting for care.
And I wasn't suggesting that urgent care is the solution. I mean, what we find now is a lot of veterans go to the emergency room. That's actually true. That would be true in the private sector, except now you have urgent care everywhere. So the solution in the community has become everybody goes to urgent care. Veterans don't even have that option, so they just overrun the emergency care setting in the VA, while the primary care system just sort of lumbers along because it's overwhelmed as well.
Well, my time is up, but I wanted to say that the veterans that I take care of in the emergency department and the veterans that I take care of in the office who are struggling with their benefits, who are struggling to make ends meet, who are struggling to get back on their feet, who are struggling to find a home, that are homeless, $50 copay for urgent care, $100 in copay for the emergency department is completely a barrier that will continue the burden of illness and disease that they already have. So I agree with that.
Thank you. Dr. Abraham, you're recognized.
Thank you, Mr. Chairman, Ms. Brownlee, for having this hearing. Thanks for the witnesses. I appreciate your very direct testimony. And like Dr. Benachek and Dr. Reeves, I come from a private setting, so looking at it from the outside in, so to speak, this should be such a simple solution, but evidently it's being muddled up and the water's being muddled by bureaucracy. I made some notes, and I'll go down them very quickly. It should seem simple. I know that the VA and we as Congress have to watch the purse, but I'm afraid we, and the VA especially, on cost is looking through the soda straw and not the overall picture, simply because we in the medical field know that if that patient comes back and back and back for for a problem that is not being addressed or not being fixed, costs just incrementally increase. And if the VA is unable to give us a cost per patient, then I wouldn't bet the house that they could give us how many times that veteran is having to come back because that issue was not resolved. And that just adds exponentially to the cost. So I'm going to paraphrase, and please correct me if I misstate what I perceived that you told us in testimony, that the way to streamline and fix this issue is, again, simple. Once in, you're in. That should be fairly simple. I like the nurse assistant line. I know that does work in the private sector. I know it worked in my clinic, saving patients going to the emergency room. We had a nurse on call, and countless of thousands of dollars, I'm sure, were saved from either waiting till tomorrow, treating that patient over the phone, going to a non-emergent facility as opposed to an ER. Mr. Blake, you said no copay is a good thing, and I would tend to agree with that. I'll tell you that. Mr. Williams, you said there's still a lot of confusion in choice. I think that goes back to both the fault of the VA and the Congress. We should have done a better job of putting it out there with bullet points and making it, a one-pager. It should not be that hard to explain this program. It should not be. Also, Mr. Williams, you said in your vision that the VA added significant more employees and you saw wait times come down. Do we know, or can we extrapolate that actually improved care, or did it just eliminate wait times? I know it's a theoretical question, but just give me a gut feeling. What do you think?
Congressman, it was absolutely important to hire those employees to cut the wait times.
So and again, I know but you think by cutting the wait, and again, I'm just asking an opinion, in a non-emergent setting, does cutting the wait time improve the quality of care that veteran gets? I'm assuming it does, but I'm asking you have talked to your veterans, do they perceive that as being an improvement of quality of care?
In Georgia, the access to care is critical, and access in a lot of our veterans' minds is interpreted as quality.
Okay. And I think one of you guys made a statement, or maybe somebody on this panel, about another issue is paying our providers, non-VA providers, appropriately enough money to come into the system. And I can tell you, it's still a very big problem. In my visit in 2016, we have arrears of the VA system to our ambulance services, to our providers, in the millions of dollars. So you are spot on there. It's a big problem. And that's, again, I'll put that on the VA explicitly if we're not paying their claims. So anything else, the no copays, the once in, all in, the increased queues, I'm just looking for simple solutions to what should be a simple problem here.
Well, Mr. Abraham, I want to go back to something you said at the beginning about escalating costs, and I'm using this to piggyback on comments that Ms. Brownlee made at the beginning. We've been advocating for travel reimbursement for, while it's a non-service connected population, it's catastrophically disabled veterans. And usually we get folks who balk at the idea that we were recommending that for non-service connected disabled veterans. But they are already granted higher priority in the VA system because of the nature of their disabilities and the ability of the VA to meet their demands for health care when the private sector struggles with that challenge. And one of the reasons we've advocated for the beneficiary travel issue is because what we've seen in our own membership is those folks who are non-service connected will choose not to go to the VA and wait as long as possible because it's costly for somebody with a catastrophic disability to fly long distances, drive long distances, or whatever it may be to go seek that care. And the long-term cost to the VA when they finally show up, because they will show up and the VA is obligated by priority to care for them, will be substantially higher. So we would hope you would take a look at that as an issue, because it's a unique population that the VA serves, because yes, they're non-service connected, but they have some of the most profound disabilities that VA serves, and that's the reason they go to the VA. And yet the VA many times ends up bearing a higher cost burden than they should have to, because the veterans are disincentivized to get that care as soon as possible.
Thank you. I'm out of time, Mr. Chairman. Thank you so much.
Thank you. Mr. Bilirakis, you're recognized.
Thank you so very much. Appreciate it. Thanks to the panel as well. Well, let me ask you a question on dental care. I know it's very limited as far as eligibility for veterans, but are veterans receiving dental care, let's say in the community, if no one is available within the 40-mile range or the 30 days? I mean, what's going on with that?
I couldn't really tell you, Mr. Barak. This is actually a very good question. I believe the eligibility for dental care, as strict as it is already, getting it in the community is par for the course for VA when you are eligible for dental care. But you know, that question really goes to a much larger issue, which is, as good as VA's plan is, as a first step towards creating an integrated community healthcare system that's integrated into the VA healthcare system, it's a good first step. But the issue is it's not comprehensive enough. In other words, the authorities that VA looked at to create its plan is not all its purchase care authorities, it's some of it. And those other parts that is not included in this plan, which could very well not be included in the solution or the next iteration of choice, as I mentioned in our testimony, if you carry that forward, you will still have fragmented care, whether that be dental care or home and community-based services or specialty care. There are other other purchase care authorities that VA has and uses that is not part of this plan.
If you, in a perfect world, is with regard to specialty care, if we wanted to open it up to the community for the veteran to have the ultimate choice, even if he lives within the 30-mile range, what have you, or she, which specialty would you recommend where the veteran would have direct access to community care? Can you give me a couple specialties?
I don't think you can cherry pick and say, well, we're just going to let this group of veterans with this unique need have this option. That's probably an inequitable
Where's the
healthcare
veteran having the
benefit.
most trouble accessing care?
Oh, well,
In what specialty area?
So a good idea, a good example would be if you were in the High Plains, cardiologists. Here in DC, a dermatologist. It really depends on what's available in the community.
Okay. So
And it
depends
can
on
vary
the
widely. There's a
particular
Merritt
region.
Hawkins survey that kind of shows that, actually.
I think that's why you can't just sort of apply a national fixed standard to it. It's when I mentioned earlier in my comments, as they flesh out the details of an integrated network, you can't just sort of lay a national standard on it and say this is what the network should look like. I think that's probably the challenge that Tri-West and HealthNet are experiencing now. It has to be distilled down to the lowest level possible. That's the idea I think that Mr. O'Rourke was trying to get at with what he was looking at in El Paso. Because you have to understand every individual city, every individual town, the rural counties across America, everything is going to be different. So you can't just say, well, we're going to grant all these folks who maybe have a cardiology need, access and nobody else, when some veterans might be perfectly served by the VA and some not in that little cohort alone.
Okay, so in other words, we would specify based on the area, the region in the country where there's a lack of maybe care, access to care in that particular region. All right, let me go on to the next question. VA's consolidation plan addresses eligibility for community care, but not eligibility for enrollment in the VA healthcare system in the first place. So the question is, do you think that a review of VA's overall eligibility and enrollment is needed at this time, and would you support such an effort? And that's for the panel.
Well, Mr. Bilirakis, I would point you to the concluding part of my written statement, which suggests that perhaps it's time to consider whether veterans should just be eligible to enroll in the VA healthcare system. The vision of the Affordable Care Act, which I hasten to mention because that brings up all kinds of political ramifications, is to expand access to care for people in general. And we fought when the law was being written for the Affordable Care Act to ensure that VA was deemed credible coverage under that law. And the law says VA is deemed acceptable coverage under the strictures of the Affordable Care Act. And yet, there's a large group of people, particularly in the priority group 8 arena, who are denied even accessing that. So why would you deny them an option for health care and say, well, you can only go over here under the rules of the Affordable Care Act, but under the rules as set for VA, you can't actually come into the system. So we think maybe it's worth considering whether, there's this fear that if you just sort of open enrollment, sort of if you build it, they will come, that it will flood the VA system. But history has never proven that to be the case. When VA's system was open, veterans didn't flood the system. Even then, fully 2/3 of all veterans chose not to enroll in the VA. So I think it's a sort of a scaring assumption that, oh, all these veterans would enroll, which would increase utilization. It might not. And I think that's, I mean, it's a high risk, but there's a potential high reward from allowing veterans to access the benefits of VA health care.
Well, thank you very much. I appreciate it. I'm out of time, Mr. Chairman. I'll yield back.
Mr. Kaufman, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Are there, and I'll ask every panelist, are there any types of healthcare services that should be eligible for choice without regards to any time or geographic requirements? And the reason why I mention this is because obviously mental health has become such a big issue for our veterans. And so we've had testimony before to this committee about VA's mental health being at times drug-centric in its treatment. And so to me, having had veterans commit suicide in my district and meet with those families and try and trace it back when it becomes evident that they couldn't navigate the bureaucracy to be able to get an appointment in time to save their lives. And so wouldn't it make sense to allow veterans to see who they feel more comfortable with, see who they want when they want in terms of access to mental health care as an example, and are there other examples? Whoever wants to start with that.
Congressman, I will say this from the perspective of with my sisters and my late wife being Marines. My wife was adamant after one visit to the VA that she would never, ever go back in after having walked through a gauntlet of men. It brought up something I did not know about what had happened when she had first joined the military. I don't think we should make women have to go through a gauntlet, because I think it also discourages some of those who need the health care from getting it because they just don't want to walk through a gauntlet of men.
Okay. Mr. Blake.
I would answer the question in this way. I would throw out the concept of choice altogether for a second. If you had a fully integrated healthcare network, which is a division I think that the VA has, even though this is billed as just for community care, the way the healthcare network should work is a fully integrated healthcare network. And you have the patient-provider relationship within the construct of that network. The veteran goes to their provider. That veteran and that provider, which is the way in the private sector it also works, decide what is best for that veteran. Should I be seen at the VA? Should I be seen in the community? What's available now? What's available later? What services do I need? So the question of choice is sort of a false question. It shouldn't be.
Well, I don't know if it's a false question to the veteran. Let me phrase it this way. Who should make the decision? Should it be the veteran making the decision, or should it be a bureaucrat making the decision? In terms of access to mental health care? Yes.
Mr. Kaufman, so this shared decision is really what we're talking about. When a veteran meets their primary care provider, hopefully it's a VA primary care provider, that discussion should go something like this. Well, it looks like, sure, that you have this condition. Here are your options. I prefer, as a provider, you go down this route. But these are the options that you can, of therapies that you can use to deal with this issue. Well, that's great, doctor. I'll tell you what, I would rather go this route. I'd rather take this option. Where can I get that care? That's the kind of decision-making we're talking about. The network should be responsive to that.
Who makes the, now, let's take a step back here.
Sure.
Who are you going to empower to make the decision? This is my question. We're not bureaucrats here.
Sure.
We're veterans. I assume everybody here is a veteran. Who makes the decision? Is the veteran make the decision in terms of their own mental health care, or are you saying that it's a shared decision between a VA employee and the veteran?
Okay. Let me give you a straight answer. There is no one.
Well, that's a problem.
It depends. It really depends.
These two veterans that I have in my district that committed suicide, they couldn't navigate this system. And so let me ask everybody one more time, as a veteran. Now, what branch were you in?
I was in the Navy, sir.
Branch?
Army.
Branch, Navy, or Army? Yes or no, should veterans make the choice of their mental health care, irrespective of the Choice Act? What's your position?
If they are capable in making that kind of a decision, yes.
Capable, great.
It should be an informed choice.
The veteran.
Thank you. Mr. Chairman, I yield back.
Dr. Wenstrup, you're recognized for 5 minutes.
Thank you, Dr. Benishek. Appreciate you all being here today. You know, my concern, and I think everyone's concern here, is that the veteran get care. And I think we get hung up on a little bit of optics. Is someone coming from private practice, I guarantee you every member of my 26 doctor group would have been glad within our practice to have a sign up front that said we're VA providers and have the VA logo there. We just don't happen to practice within the walls of the VA, and in part because it's a mess to deal with from the bureaucracy, and you can't be productive in the way that you can in private practice for a variety of reasons, and we won't go into that. But even recently in a hearing, you know, VA officials were saying, oh, we are seeing more patients than ever before. That's because they increased the number of doctors and expanded their hours, but they didn't get more productive. And when you're in private practice, you got to maintain the quality if you want people to keep coming to you. That doesn't exist in the VA, although I think we have some great providers, so I'm not knocking that, but the system makes it very difficult to be productive. So I'm going to ask you, do you think there's an optical problem? And I don't like when we keep saying non-VA providers. And I think we should just say that they're VA providers. They just happen to be outside the wall of the VA. And in that case, you give people a choice on where they want to go. And when you talk about lack of specialties in different areas, well, that exists for everybody, and people make a choice on where they live. Some people move close to a hospital because they got a heart problem. I mean, those are choices people have, and we can't expect the VA, just because you're a veteran, have every specialty follow you around wherever you happen to live. So people have to make choices like that, whether they're veterans or not. That's just the reality of things. So my first question is, should we stop calling these providers non-VA providers like they've got some stigma? And do you think that veterans really feel that they have to be within those walls to get proper care?
Congressman Wenstrup, the idea that calling private providers non-VA providers is a little bit of a misnomer. That really talks to not the quality of care that private providers are able to provide. It doesn't talk about what it really talks about is what is the kind of care VA provides. VA is a healthcare system unlike any other healthcare system in this country. Its dependencies stretch beyond the walls of a hospital or a CBOC. It has to work with VBA, NCA, IHS, rural community health centers. It is part of a social support ecosystem.
But there still be that link.
I understand there should be that link. So whether you call it a VA provider or not, the recognition has to be that the VA provides a different kind of care, that it has different responsibilities. It has a teaching mission, it has a research mission, it has all sorts of
You know what? That veteran who's sick doesn't care. They want to be seen and they want to be taken care of. They're not saying, oh, you do research here? They don't care about that. It's about getting the veteran taken care of. And so, anyway, I'm just going to move on from there because I want to make a point of something that we've discovered through this committee. When there was a study done, and you talk about cost, and we've got to be concerned about cost. But a well visit to an average primary care doctor is about $85. Pay the copay if they want to go outside the VA. Guess what we discovered it costs? Because, see, no one in the VA talks about what it costs for your physical plant, your insurance, your supplies, your staff, your administration. They don't even know what that is until this study was done. It's about $400 to $600 per patient visit to go to the VA. We can't do that forever, and it doesn't make any sense. When you send someone outside the VA, and maybe if they want to go there, it may be $85. And the VA is not picking up all the malpractice and everything else. And I think we got to consider that, and I want the veterans to have a choice. But as a provider, you know, I would say, you know, hey, I'm a provider for Blue Cross Blue Shield, United Healthcare, the VA, whatever. I'm a VA doc. And I think we got to break that stigma and really look at what we're doing so the patients do have a choice between going to the VA, going outside it if that's their preference, but really start to look at the dollars and cents of what's taking place within the VA, where it costs way too much to see a patient. Now yield back.
Thank you, Dr. Wenstrup. Does anyone else have a question for the panel?
I really appreciate all of you coming here to testify, and I really welcome your input as this process goes forward. Feel free to, you know, come before any of us with further ideas as we explore how to make this better. So I really appreciate that, and you're hereby excused from the panel. Thank you. Joining us on the second panel from the Department of Veteran Affairs is Dr. Baligh. I'm struggling with your name. Sorry, Doc. Yehia, the Assistant Deputy Undersecretary for Health for Community Care. He's accompanied by Kristin, Cunningham, the Director of Business Policy for the VA's Chief Business Office. Thank you both for being here. Dr. Yehia, you may begin when you're ready.
Thank you. Good morning, Chairman Beneček, Ranking Member Brownlee, and members of the subcommittee. Thank you for the opportunity to testify today regarding the department's plan to consolidate community care programs, specifically streamlining eligibility criteria. I'm accompanied today by Kristin Cunningham, who's the Director of Business Policy. I want to acknowledge our VSO partners. We've been working with them hand in hand since we started this process, and also your comments, Mr. Chairman, on the need to get to one system that works for veterans. And I'm looking forward to discussing a little bit more about those clinical criteria that were mentioned. This plan aims to clarify eligibility criteria, build on existing infrastructure to develop a high-performing network, streamline clinical and administrative processes, and implement a continuum of care coordination services. These actions will improve access to care, expand and strengthen our relationship with community providers, allow us to operate more efficiently, and improve the veteran experience. As you know, VA is taking part of an enterprise-wide transformation called MyVA. MyVA will modernize VA's culture, processes, and capabilities to put the needs of veterans and their family members first. Just a few weeks ago, Secretary McDonald highlighted the department's 12 breakthrough priorities, all of which are designed to improve the delivery of timely care and benefits to veterans. One of those priorities is to improve community care. Community care has been and will always be a vital part of VA healthcare for veterans. In 2015, VA issued authorizations that resulted in about 12 million community care appointments, and that's compared to 8.8 million in 2013, representing an increase of about 36%. Even though we have been providing more community care, we are eager to seize the opportunity to improve the experience for veterans, community providers, and our employees. However, we need help from Congress to consolidate the complex and varied eligibility criteria for community care into a single set of standards. By doing this, veterans will have a clear understanding of their eligibility for community care, and VA and community providers will have a significantly lower administrative burden. The eligibility criteria outlined in the plan aim to increase access to timely care and patient choice while being mindful of taxpayer dollars. The plan gives veterans a choice to access some or all of their health care in the community if they meet one of the following criteria that's related to access, geographic distance, and availability of service. A veteran would meet the access criteria if they are unable to schedule an appointment within VA's wait time goals for providing that service or within the clinically necessary time frame indicated by their provider. In terms of geographic distance, a veteran may receive community care if they're 40 miles or further driving distance from a primary care provider, or they face an excessive burden in accessing a VA facility. Lastly, a veteran may access community care if the VA does not provide the service or if there's a compelling reason why the veteran needs to receive community care. By implementing a single set of eligibility criteria, veterans will have a clear understanding of their community care benefit. However, built into these criteria is a flexibility that I and my fellow clinicians at VA need to respond to unique circumstances. This is critically important to ensure that we meet the needs of individual veterans. The plan also addresses the challenges that many veterans face today when seeking emergency room care within the community. Due to complex laws and processes, VA is many times forced to deny a significant number of emergency treatment claims, leaving some veterans to shoulder that financial burden. By tackling these pain points, we anticipate that it will improve reimbursement of emergency room claims and reduce the need for manual review of every claim. In addition, the plan asks for congressional authority to offer urgent care services in the community. This action will increase access to care and reduce the number of emergency room visits. We are eager to move forward, and we are open to any ideas that veterans, Congress, veteran service organizations, and other stakeholders may have. We recognize this must be a collaborative effort and need Congress to provide necessary legislative changes and support moving forward to consolidate care, including the enactment of provider agreements and flexibility in funding for community care. I appreciate the opportunity to appear before you today, and I'm prepared to answer any questions that you and other members of the subcommittee may have.
Thank you, Doctor. I'll yield myself 5 minutes for questions. So can you go into a little more detail about, one of the big problems we have, of course, is this emergency reimbursement issue. And, that happens all the time where, a veteran goes to an urgent care clinic or the ER in the local hospital and then, tries to get that approved, and there's a big, how is that, can you give me, that's a pretty good example, I think. So how specifically are you going to fix that problem?
Thank you for that question. We knew when we started this work we had to tackle the emergency room benefit. We've talked with a lot of veterans. We received a lot of letters, as I'm sure you have and others, about the challenges that many of them face when accessing community care as it relates to the ER benefit. And the biggest challenge is that they don't know if VA is going to end up paying for that care. And I think that creates a perverse incentive. Many times they delay that care, or they feel they have to drive to a VA to be seen. And part of that is the way that the laws and regulations have been written over time. We can't provide that clarity that we need. And so what we're hoping to do in the plan is to streamline that. We're using principles based on industry. So a lot of the things that we talk about in the plan of consistently applying what's called the prudent layperson definition of ER, the idea of co-payments to make sure that we incentivize the right health behaviors, those all came from TRICARE, from health plans. They're standard and common practice in many health systems. And then by doing that, we hope to minimize by a significant amount denied claims and kind of empower our patients and veterans so they know that when they access the ER care in the community, that VA is going to be picking up the bill and they won't be shouldering that financial burden.
Yeah, I guess I didn't quite get I understand your thoughts, but specifically sometimes that how are you going to get the VA to be assured that they're going to be is there going to be a central number to call? I mean, your goal is, you want to make it right, but the reality of it is, it's not right now, and you didn't tell me anything specifically that's going to make it right, from what I could understand.
Let me clarify. So in our plan, and to the committee, we've also provided some technical assistance that has specific legislative language to make it right. Right now, when it comes to ER, under our current authorities, we're the primary payer when it's service-connected care. We're the payer of last resort when it's non-service-connected care. And then there's a whole bunch of different criteria that are outlined in rules and regulation where if someone passes a VA or they...
So, like, a question is, is there somewhere in your plan that will allow a veteran to make a single phone call and find out? I mean, it doesn't sound like you've said anything that allows that uncertainty to go away.
Well, yes. I think the first step is we have to actually consolidate and fix the problem. And once we fix it and it requires congressional action, then we communicate and make sure that folks understand what it is.
I'm not sure if that requires congressional action. I think it may be more of a bureaucratic solution. I want to discuss this, one of the things you said in your statement, the distance, and then how do you define unusual or excessive burden that may necessitate community care? 'Cause that's a vague criterion. Can you tell me about that?
Sir, I'll help Dr. Yehia with that. In our current choice law, the additional enhancements that were given to us in the May law, we were able to define the unusual or excessive burden. We implemented 3 of those provisions in June. The last provision required us to further define in regulation. We did that in the beginning of December and then rolled that out to our facilities. And we looked at that, providing either the ability for clinicians to make a medical determination that the person's condition required them to get care closer to their home, or we identified things that were just the nature, simplicity, or the frequency of the services. So earlier during the VSO testimony, there was some discussion of getting, for instance, eye exams or audiology exams in the community because they're simple in nature. And those are actually some of the examples that we use when we talk about the simplistic nature of the type of service and being able to get that care under the unusual or excessive burden provision.
All right, thank you. I'm out of time. Ms. Brownlee, you're recognized.
Thank you, Mr. Chairman, and thank the panelists for being here. Just a very direct question. If you could just give me the rationale the VA has for imposing the copay of $100.
The copayment of $100 is meant to make sure that that we provide care in the right venue. Many of our ERs are clogged up today, and there's long wait times when folks go to the ER. And part of the problem is that a lot of non-emergent care is being driven to the ER. And increased access to urgent care, which is what we're proposing in our plan, a robust primary care healthcare system, those are all kind of tools in the toolbox to ensure that folks use the right setting. So the idea of the copayment here is to make sure that folks are able to seek the right care setting for when they receive their care.
Did you evaluate other ways in which to accomplish the goal that you're describing?
Yes, and so I think I view this as more of like a suite of packages. When we look at kind of the data that's out there on how to make sure that we appropriately use ER care, some of the things that come up is if you have readily access to primary care. So there's initiatives that are going on at VA today that are working more on providing increased access to same-day primary care. Urgent care, which is something that we propose in the plan as another option. If you have the sniffles, you need a shot, you can go to urgent care rather than the ER. I think the nurse hotline that was suggested by the VSO partners is another tool that many health plans, including TRICARE, use. All of those things are tools in the toolbox. I don't think they're meant to replace one or the other. They're actually supposed to be kind of supplemental. So at the end of the day, we make sure that folks are using the right setting. In the future, as we kind of build this high-performing network, one of the other things that we really hope to do is focus on what's called super utilizers, and this came up a little bit earlier. Those folks that are constantly going to the ER, there's a reason why they're doing that. Sometimes they don't have the right case management, or they need other support, or need to be connected with certain services. And robust health plans and high-functioning organizations are able to identify who those folks are and provide services that they need. So I think at the end of the day, co-payments, as I said, is just one tool that we hope to use to make sure that folks access care in the right setting.
Well, it just sounds to me that you've mentioned a couple of tools in the toolbox, and so it seems to me that we should try to utilize those tools first before we use a more punitive tool of $100 copay. But I'm sure we'll be talking more about that as time moves forward. So you had mentioned that appointments in community care have grown over the last couple of years, and you talked about 12 million appointments within the community care. So what's that compared to? What's the amount of appointments that the VA has provided over the same period of time? Is this a 10% number of overall?
Yeah, I actually don't have that number off the top of my head, but I can take it for the record.
And in terms of the, the 30-day wait and the 40-mile driving distance rule, is the VA trying to look at other approaches on that, or have you decided for cost purposes that this has to be a hard and fast rule? And I think we're trying to drill down on what the costs are. I mean, Dr. Winstrup talked about, cited examples where it might be a lot cheaper in the community to receive services. So if you could address some of that, please.
Sure. So I think an important point to keep in mind is we are kind of considering this as an entire kind of healthcare system, so the VA and community care. I view them as two sides of the same coin. The criteria that are set that relate to access, wait time, and availability of service are really meant to serve as the floor. So we heard a lot of comments about clinical criteria. Embedded into each of those, as I tried to highlight in my opening statement, are decisions that the doctor and the patient together in the office can make. But the challenge with just keeping something very local is we won't be able to explain to our veterans, can I access community care? The answer would be, well, you have to talk to your doctor. And I don't think that's good enough. I think what we wanted to do is provide at least some clarity and transparency, and those are based on when you can't see a primary care doctor, they live far away from you, 40 miles driving distance, then you have the choice to access care. There might be criteria above and beyond that that we described a little bit in terms of unusual and excessive burden that in the office people can use to decide, but at least they know at minimum that they can access community care if they hit that standard. The same thing goes with wait time, and the same thing goes with availability of service. So I think the concept here is to make sure there's a level of transparency onto what people's benefit is. If it's completely left up to be in the office, then I think we're left a little bit of where we are today and before choice, where people don't really know what are the criteria that they have to access community care.
I've exceeded my time. I yield back.
Dr. Wenstrup, you're recognized.
Thank you, Mr. Chairman. Doctor, I appreciate your approach to this. I think you're trying to find the best practices, and you're keeping the veteran and the patient in mind as much as anything else, and to have that continuity of care. And I'll go back, and I'm speaking from my personal experiences as a practitioner, and for those that I know that are still out there every day that want to take care of veterans in their private practice, or some that give one day a week to go to the VA. The frustration at the VA is, I spent all day and I operated on 2 people. If they had been part of my system here, I could have operated on 8 veterans today and with the same results. So I think you get that and understand where we're going, and I think you're heading in the direction where you see that the VA has to make those types of changes too, and try to get it to be more of a balanced type of system and not so drastically different from one to the other. Can you comment on any efforts in that direction?
Yeah, I really appreciate that. I think when we started kind of this work, and part of the reason we built this high-performing network is really putting at the center our partners, especially like DOD, our federal partners, and academics, because I practice both at the VA and across the street at an academic facility, and I've experienced similar things. And so the concept here is, how do we make sure that we are good partners for our community providers? There was a number of comments earlier about that. I think the more consistent we can be and similar in areas to the private sector, the better. I think there was a few comments about the different paperwork that our community providers have to fill out to partner with us. That paperwork burden should be exactly the same as it takes for them to sign up with a United or Humana or someone else. So I think our intention and our goal in the plan is to move as much as possible to what the industry does, so that we don't put any excess burdens on community providers, and for that matter, our employees to operate differently. The thing that gives me a little bit of pause is once we start getting off these little one-offs and things like that, we create complexity and we lose that. And so that is something that we're trying to continue to push forward, is being respectful of the differences, but at the same time really pushing towards that industry standard.
Yeah, and to that point, one of the complaints that I hear is, well, I'm seeing patients now, but I'm waiting forever for pay.
Yeah.
Whether it's hospital systems or private practice, and that's very frustrating. And there's people that do this all the time, and maybe they should be doing it not within the walls of the VA, taking care of those claims. Might be more efficient and better. I don't know if you have any comments on that.
I do have comments on that,
Okay.
and I'm looking forward to the next hearing that discusses specifically prompt pay and claims, because I'm on the phone all the time with health systems that are frustrated with choice. I think, in the short amount of time that we had to stand up this program, ourselves and our contracting partners, I think, have done a good job, but we are not where we need to be. I think your comment about, claims, it actually just so happens that today we released our first draft statement of work for what will be a new contract to support kind of this high-performing network, and we're seeking input from industry on that. Part of that statement of work includes processing claims, and so I'm happy to share that with you. I shared it with the committee members or committee staff earlier this morning, but I think you might be interested in looking at some of those.
No, I appreciate it, and I think the more you approach those difficulties, if you will, the more you'll see excellent providers in the community taking care of veterans, and they want to anyway, and I think that that'll be a win-win for everybody. So, thank you. I yield back.
Thanks. Mr. Takano, you're recognized.
Yes, thank you, Mr. Chairman. Dr. Yehia, as you streamline the eligibility requirements for the various care in the community pathways, what impact do you think it will have on the number of veterans who get their care in the community? Do you have any idea of how many more veterans will be seen through this new Veterans Choice program?
So I'll start, and I'll ask Kristin to jump in. We've been seeing more and more unique veterans using community care over the last couple of years. The numbers that I just received recently were, in last fiscal year, we had about 1.5 million veterans, unique veterans, at some point access community care. That's about a third of our veteran population is receiving some of their care outside of VA's walls. And that really gets to this whole concept of this integrated healthcare system that's both internal VA care and kind of community care. We think that as we improve the program, including streamlining eligibility, making sure that it's clear, we have a good network that includes the best performers in the private sector, that more people will use it. And when we articulate the cost of the program, we think that increased demand will come as the product is better, which will also increase the cost in some ways. So I think that I don't have like a crystal ball of the exact number, but I think the idea is, as we make it better and simpler and easier to use, more people will use it.
Well, that you kind of alluded to what I wanted to get to know is, do you have a ballpark projection on the overall estimated cost of the program to be? If you, as you kind of rough out this number, aside from the $1.5 billion for emergency treatment? It's going to be helpful for us to kind of know this.
Yes, and I can't agree more. So in our plan that we submitted, there is a section on specifically on costs. We think that increased demand will be in the order of about $2 billion annually for the program. That includes a lot of the kind of eligibility criteria that Congress helped us out with over the course of the last year as we kind of continue to iterate and improve the program, kind of removing the enrollment date, some things about changing from a primary care provider to a primary care physician. So there's been a number of different things that have been passed over the last couple months that expand eligibility. And so, but roughly speaking, I think with the eligibility criteria that we're proposing in the plan, it would be about $2 billion on top of the care in the community budget.
On top of the, what was it, we approved like 10, 15?
Yes, about
$1 billion. We haven't, we've not used, we thought we have it used up by now, but we've seen a number of impediments to actually spending down that money, and we thought we'd have to be appropriating more. How many different appropriation accounts affect non-VA care, would you say? I mean, my question is really, how many different accounts do we have to sort of deal with for this non-VA care space?
So I don't know the exact number. I know we have more than one, and that's been a challenge that a lot of our field folks tell me. Part of what we're proposing and one of our legislative proposals is to get to that one funding stream. We did have some flexibility at the end of the last fiscal year, so thank you for that. That allowed us to kind of access the choice fund to pay for community care. I think it will be very important to have one pot of money, one funding stream for community care, so that our clinicians and our medical centers know exactly how much they have to spend in this area. This has been a challenge because right now we go through choice, and if something doesn't work, we use another pot of money, and it creates unnecessary redundancy. And so getting to that one funding stream, I think, will be important.
I mean, you might have already covered this. I just sort of had jumping between committee meetings here, but how much will extending emergency care to veterans cost? Did you already mention that in your testimony?
I did not, but it is in the report. It's on the order of about $1.5 to $2 billion. That's both ER care and urgent care.
I'm going to ask you this sort of offline, but I'm real curious about drug treatment for veterans, whether it includes rehabilitation, just to what extent we have case management. I just want to understand that better in terms of our vets that are coming back with PTS, and then some that are having some real substance abuse challenges. Mm-hmm. So I'll follow up with you with the department later. But Mr. Chairman, my time is up. Thank you.
Mr. O'Rourke, you're recognized.
Thank you, Mr. Chairman. Dr. Yehia, thank you for your testimony and for all of your efforts to transform the VA and improve access, quality of care, and outcomes for veterans. Earlier in the day, I was at a conference that Undersecretary Shulkin organized around preventing veteran suicide, which I would argue should be the priority. And the word priority means something, right? If you prioritize something, it puts that at the top of the list. So I understand that there are 12 breakthrough priorities that the Secretary outlined. I know there are a lot of moving parts, and there are a lot of things to improve and to work on. But what strikes me is that if we really think that we have a crisis in veteran suicide and access to mental health today, and it really requires urgency in resources, rethinking how we deliver that care and provide access to it, then we should really be organized around that. As you know, and just for the benefit of the committee and others who might not, in El Paso, which had the worst mental health access rates in the country and still struggles, I think we're third from worst today, which is an improvement. We essentially adopted a plan as a community with the VA and really with your help to prioritize access to mental health care and to try to prevent veteran suicide. And the idea is that as important as it is to see a podiatrist to get your foot fixed, or an endocrinologist if you have diabetes, or a dentist to get your teeth fixed, preventing veteran suicide is more important than all of those, and ensuring that if you go to the VA, it is I know this is a term of art, but it is a center of excellence for PTSD, TBI, those unique conditions associated with combat and service. And the VA has helped by piloting a navigator concept or care coordinator who helps if you have one of these unique service-connected conditions. You're seen in the VA by hopefully a world-class provider. If not, we're going to prioritize your care that's comparable to what a civilian would experience to the private sector. We've got great partnerships with Texas Tech, which is providing 5 psychiatrists so that we can expand capacity for care in the VA. And yet, we just looked at the numbers. You have 116, or Congress has authorized 116 mental health provider positions within the El Paso VA. And right now we're at 91 filled, which leaves us 25 short. And I would argue that 116 is probably too little to meet the demand that you have in El Paso. So what do we have to do? We've adopted the plan. We've got additional resources. If we are maximizing capacity in the community and implementing this transformation plan that you and the Secretary have introduced and touted, and which I'm a big fan of, why aren't we seeing better results in terms of meeting what I think is the single greatest crisis facing veterans in this country, which is 22 veterans a day taking their own lives? If that is truly a priority, why are we not beating all the bushes, taking over the airwaves to recruit those mental health care providers to communities like El Paso and others that are historically underserved, where I know for a fact, because I talked to the surviving family members, that veterans are killing themselves because they don't have access to mental health care? Why can't we hire those 25 positions? What's the holdup?
So I can't agree more with your sentiment. And as you know, many of the elements in the plan that you had for El Paso are there's a lot of that in the plan that we presented for the entire VA. I think the part of the challenge is, as you know, to quote Secretary McDonald, you know, the VA is the canary in the coal mine. I think we have to get out there and do more recruiting. I've been on a number of trips with the Secretary, speaking at grand rounds of and various hospitals across the country, trying to recruit doctors, specifically mental health professionals and nurses, to the VA. I've done it by myself as well, and I think we need to do that. I think we have an opportunity as we start to kind of change the message a little bit about where VA is going.
Let me interrupt you just because
Sure.
of very little time. My fault for taking too much time at the outset. But with the chairman's indulgence, could the VA instruct the director in El Paso, don't hire any more podiatrists or endocrinologists. You've got them in the community. You can refer them. That is a condition comparable to what the civilian population has. PTSD is very unique to veterans. Only hire your traumatic brain experts, your PTSD experts, your psychologists, psychiatrists. I recognize your canary in the coal mine analogy that medicine in America is struggling with this, and yet there's a way to resolve this with the current capacity. I know there is. I know there are psychiatrists and psychologists working in private practice who could be brought over to the VA with the right inducements, focus, and leadership. Are we going to see that this year?
Well, I know that, you know, as you know, Gail Graham, who is working in El Paso at the medical center there, I think she's pulling out all the stops to try to recruit as many of those professionals as possible. I don't think the idea that, like as you mentioned, there's approved FTE slots for those. So I don't think that a podiatrist is standing in the way of a psychiatrist coming in the door.
I'm talking about a single-minded, almost exclusive focus on getting that up. Doesn't mean that other things are unimportant. All these conditions are important. I would just say this is the most important preventable way
I think
that
that's something
veterans
that
are
I think
dying
is something that we have to we should chat a little bit more about that. I think there may be some different tools that we can use.
Okay, thank you. Thank you, Mr. Chairman.
Ms. Custer, you're recognized.
Thank you very much, Mr. Chairman, and good morning. Great to be with you. I had a quick local question just off the bat, and we've talked about this in the past, but New Hampshire, Alaska, and Hawaii are the 3 states without a full-service VA hospital, and we had a special agreement under the previous rule to drop the 40-mile requirement down to 20 miles. I'm just wondering, the last time we talked, that was under review, and I wondered if that process has proceeded since November.
Thank you. We have continued to engage with various stakeholders, as you mentioned, Alaska, Hawaii, and New Hampshire. I've had calls with the field leadership in all of those different states to try to get a good understanding of what their specific needs are. This is a tough issue, and I'm looking for kind of suggestions and ideas here as well, because at one side, we want to make sure that we streamline the program, create something that's easy to understand and administer. And I think the more nuanced or one-offs that we do, the more complexity that's built in. So I want to be respectful of the local circumstances there, but at the same time, I'm also keeping my mind on how can we make sure that there is some uniformity so that every state is not treated differently. So with all that said, I think some of the criteria that we have articulated in the plan really do provide good access to care for New Hampshire specifically. And one of the things that I think a lot of people sometimes gloss over, the availability of service, is such a key component, because if that service is not offered at those centers, it's automatically folks have the choice in the community. So even with the current criteria, I think that the folks specifically in New Hampshire will be well served.
And I think one way to do that is the expansion of the CBOCs, community-based outpatient care. We just opened a beautiful new CBOC in Littleton, New Hampshire, but just for you to take back, I am still waiting for progress on 2 others, one in a town called Colebrook, New Hampshire, almost to the Canadian border, and another in a town called, that we call Berlin, New Hampshire. And they have to do with negotiations that are going on with community-based care and partnerships, which are a good thing, but I'd love to get a little shoulder to the wheel here from headquarters in DC to move those along. I also wanted to just talk about how we are very frustrated by the third-party administrator, and I know that's not the purpose of this hearing, but I want to put that complaint out there. Senator Shaheen, Senator Ayotte, and I have done a series of events around the state, talking directly with veterans. This is our primary, the phone calls that we get in the office. It's just very, very frustrating. And I know that the VA physicians and staff, medical professionals, would prefer to be making the appointments anyway, because they would prefer to have that relationship with the community provider, get the records back, be able to call the patient and say, don't forget your appointment tomorrow. So are we making any progress on that? Because frankly, I'd rather just take that back. And this third-party administrator is not working out for my constituents.
Yeah, I appreciate that. I think I have a call with some of those senators later this week. And I will say this, that our partners are our partners. We modified a contract at the very beginning to implement choice in a short amount of time. That contract, that PC3 contract, was not designed to run the choice program. It just wasn't designed to do that. With that said, as I was mentioning a little bit earlier, today we released the statement of work. It's a draft statement of work, so it's the first step in a contracting process. I think you'd be happy to note that in that contracting process, or that statement of work, the scheduling piece would reside at the VA and not with the contractor. So we are making progress. I think it's going to take some time for us to get there, but I've heard from the medical centers, I've heard from veterans, and I think that's a direction that we want to move. So slowly we continue to provide oversight and work with our TPAs to improve their performance. But in the end, when we are drafting the right kind of car to drive this program, those things would be residing on the VA side, not on the contractor side.
That's good news, and I apologize for missing that earlier. I was over in ag talking about veteran farmers, so thank you very much for your testimony.
Thanks, Ms. Custer. And I reiterate or echo your feelings about this third-party administration thing. And I realize that there was an urgency in getting the choice started. I'm going to ask a couple quick questions here, too. Do you know when the choice fund's going to be depleted this year?
So when to do a little bit of math, we started with a $10 billion. Last year we spent in last fiscal year about $3.5 billion. This year we're anticipating about $2 billion, and then the remainder will be the year after. I want to caveat that just a little bit. Over the last 3 months, we've seen kind of a dramatic increase in choice use, almost double the 3 months prior. A lot of that has to do with more proactive outreach to veterans. So rather than kind of the onus on them picking up the phone and calling, we are doing the calling and saying, would you like to partake in choice? Is this something that you want? And we've seen a dramatic uptick. So that's a little bit of the projections. I think we still haven't reached kind of steady state.
Okay.
So we'll get there.
Is the $2.1 billion estimate per year above current non-VA care costs expected to be the yearly program estimate going forward?
Is that in the outline in the plan?
Well, I mean, you estimated me $2 billion more. Is that the estimate?
Yeah, we
increase?
estimated the cost for the first 3 years. It's, as you know, it's a little hard to try to predict past that, but in those first couple of years, it would be $2 billion on top of the normal community care budget.
So does the 2017-2018 budget request reflect the numbers that we've been talking about here? Isn't that coming out shortly?
I don't think that's. Let me take that back.
All right, all right. Any other questions? Thank you very much for your being here today, and you can look forward to some further questions from us as we go forward here. I ask unanimous. You're now excused. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. And without objection, that's ordered. The hearing is now adjourned. Thanks.